Merci. Alors pourquoi finalement envisager ce sujet? Tout d'abord parce que, vous l'avez vu lors des exposés précédents,
Why are we thinking of looking at this today? As you've seen in previous presentations, these viral infections are something that are of great interest to the intensive care workers and microbiologists and epidemiologists. Epidemiological data in favor of the existence of viral pneumonia that has appeared in patients who have been ventilated while in ICU has led to the colossal progress in the microbiological diagnosis that has occurred over the last 10 years. So we're going to be talking a lot about hospital-acquired viral diseases. We're going to be talking a lot about herpes simplex virus, cytomegaloviruses, and others. Some of the patients that present with these infections are infections that have a late onset. It is when the inflammatory response has been somewhat attenuated, and on the contrary, we end up with an anti-inflammatory response that appears, and that is when a viral infection may appear, which could be a factor that is going to have an impact on morbidity and mortality. Now, this might be an emerging subject, but we now, for quite a long time, have been finding the presence of certain viruses in our patients. These were patients who were presenting with ARDS, particularly in burn victims. For more than 30 years, this is something that we had actually identified. But back then, we had not necessarily made the link between the presence of this virus and its pathogenicity. For the CMV, the cytomegalovirus, here too, this is something that we actually stumbled across. In a nutshell, what happened was that we had done some work comparing the diagnostic performance of different techniques of microbiological sampling, brushing, tracheal aspirates in our bacterial nosocomial patients. So our reference was a histological test on the lungs of deceded patients, and we asked the anapathologists to present us with patients and the results of their tests, and to classify their patients as to whether or not they had any bacterial form of pneumonia. And in some of these patients, it was not at all a question of bacterial infection, but we did have certain signs of pneumonia that were confirmed. So once we saw that we had patients that had an ARDS that was persistent, and we also noticed that it was possible to do the biopsies at the bedside. So there was that was an indirect result of the clinical research, and we began to find authentic viral pneumonia, but in living patients this time. It was a challenge for us. So this was a paper that we have looked at in all of the IC units, because many people were actually challenging the existence of these SMV pneumoniae. They thought that we were mixing up what was going on with the RSV patients. So what we first started with, because it was the one that has been identified for the most time, is HSV. Most of the time this is asymptomatic, and this is when we actually assist in some type of reactivation. The virus, however, remains in a healthy form in many of the nervous systems, particularly in the trigeminal ganglia, or in the superior cervical ganglia, or in the vagal ganglia. We had known for some time that the oral shedding of HSV is linked to the severity of the patient's health. If you compare the healthcare givers with the orthopedic patients or the ICU patients, you see that oral shedding actually increases in proportion with the severity of the patient. There's nothing really new there. For the oral shedding, we think that that is going to affect between 20 and 30% of patients when we actually do these, when we take these samples. The peak is obtained around the 10th day. Here on the slide, you can see the typical evolution of microbial growth with an extremely early onset appearance after installing mechanical ventilation. You have a peak between the 8th and the 10th day, and then there is a viral decrease, particularly for the OCMV, particularly for the CMV. It happens a little later there. Now, the presence of a virus doesn't necessarily mean that there is a bronchopneumonitis, and Charles Edouard was perfectly right when he tried to correlate the culture with more solid data, particularly data of HSV bronchopneumonitis, which is a clinical symptoms of clinical deterioration. And there can also be signs of cytopathogenic activity, whether you can have some type of HSV inclusive cells. And he also showed that if you do a quantitative determination of the number of copies from the BAL, with a threshold of 10 to the power of 8, you end up with a very good indication of HSV bronchitis. Certain information has also been discovered concerning the reactivation of HSV1. Now, normally there is a simultaneous appearance or an initial colonization of the oropharynx, a main source, or afterwards. There is no nosocomial transmission, and that's very important because the healthcare givers sometimes have cold sores, but they don't seem to be the result of a transmission. We have looked to see whether when they had herpes patients, they never had the same genetic strain as the strain found on the health givers. Now, concerning the impact of the presence of this virus on the prognosis, there is no official proof of a link here of HSV and pathogenicity, but Tuxin for the last 20 years did a study on some dozen patients, and he compared acyclovir to a placebo. So this was an ARDS patient double-blind randomized study, and he tried to see whether there was any reactivation or not. And he showed that in giving acyclovir, you decreased the reactivation. There was no impact on mortality, but again, this was a very small study. There are different epidemiological studies that seem to suggest that there can be a potential association with mortality in ICU. What's also interesting to note is that this is associated with the presence of HSV. There is a higher rate of bacteria and a higher rate of respiratory distress. And this was found in Charles Edouard's work with an increase in the number of bacterial pneumonia acquired under mechanical ventilation. So it's ventilator-associated pneumonia. For CMV, which is another herpes type virus, on the biopsy, surgical biopsy data, so this is patients that are still alive, it's not post-mortem, in a series of 100 biopsies, we only found 3 cases of herpes for a far larger number of CMV pneumonia. So the direct impact on the lungs seems to be a little less serious for HSV than for CMV. Maybe because of associated infected bacteria, that prognosis could change. In CMV, we talk about a CMV infection when you're talking about a viral replication and when there is organ failure. We don't normally see patients with a primary CMV infection. For us, what we see is a reinfection. And why does it often occur in the lungs? Simply because it is a major site of CMV latency, particularly within the monocytes and the macrophages, and that is where the latency, that is where the CMV will lie latent. And also in the alveoli, when you consider the number of alveolar macrophages, it might explain why this systemic disease often attacks the lungs and is much more virulent than elsewhere. Now, for the incidence of active CMV infection, this is going to depend on the diagnostic method. If you're simply looking at the cultures, then we found between 0 and 12 to 15%. On an average, it was 12%. If you use more modern methods, antigens or viral PCR, then you end up with about 20% of patients who present a CMV reactivation. From a clinical point of view, what does that actually look like? It doesn't look like anything particularly outstanding. Don't expect to see something like an interstitial pneumonia as you would see in cases of influenza. These are patients who are not necessarily feverish. This is one of the tests that we did on some 40 CMV active infections. Here is the X-ray. You can see that there are local sites. There is an impact on oxygenation, but it's minor. What you have to be careful of is that often there is a hepatic aspect as well. So you have hepatic atrophy because there are macrophages in the liver. And sometimes you have a little cystitis or cholestasis, which might help you in your diagnosis. Now, I told you that with HSV, the onset is later. It's often at the end of the second or the third week of ventilation that the samples come back positive, be it in the trachea or in the blood. What kind of patients are affected by this? Any kind of patient. This is work that was done by Jabert. It can be patients who are suffering from polytrauma, patients with problems, surgical patients, medical patients, patients who had esophageal cancer, or also patients who had peritonitis, community-acquired peritonitis. For the effect on prognosis, several studies have shown that this is linked to the duration of ventilation, duration of hospital stay, to mortality. And in the left-hand column here, in this work that was done also by Jabert, you have 40% who have positive antigen, and there appeared in those cases to be a higher level of bacteria. This meta-analysis, as others, have also showed that there is a possible link between CMV and mortality in ICU. In another series that we looked at, as in Jabert's series, as with HSV, we identified a much larger presence of bacteria, be it in urinary infections or else here, where in patients with positive antigenomy to the megalovirus. This data has also been confirmed in other work, one that was very recent. Here you can see that there is a greater bacterial infection, greater fungal infections in patients who have an HSV reactivation or a CMV reactivation. We have also taken a look at some of the immune modifications before the appearance of CMV in this work where the sampling was done on a twice-daily basis. the NK cells produce less gamma interferons before the patients actually activate the CMV. And then maybe what also is going to differentiate this from HSV, there is an association that has already been mentioned, association between CMV and fibrosis in a model experiment of peritonitis. In a mice experiment, Charles Cook showed that in patients that had a CMV reactivation tended to develop more fibroses than, I think I said patients, but actually I'm talking about animals here, than control animals or animals that have been treated with acyclovir. So how could HSV or CMV give rise to an adverse outcome in ICU patients? Well, either via direct parenchymatous injury, direct lung injury, or an indirect mechanism by potentializing the inflammatory reaction. And that's why we find quite frequently that there is an association with ARDS, and we find that there can be an upregulation that will modify the prognosis. So we're going to try to answer this question by taking a look at this PTH study. This is a preemptive study, be it in the rhinopharyngeal region for HSV or elsewhere for CMV. We're going to treat the patients and see whether this is going to have an impact on mortality or the ventilation duration. And our main judgment factor will be the number of days that they survive without any adjacent mechanical ventilation. We did this with Michel Wolf and his équipe and Jean-Edouard Luit, as well as with others. And in this study, we have looked at 480 patients, and after 1 year, we have actually included about a quarter of them. There are other agents, infectious agents as well, that have also been mentioned in literature, whose pathogenic role remains to be confirmed. We've talked about community-acquired aspects, but this is also valid in nosocomial infections. Microbiologists now can isolate all sorts of different forms of bacteria without really knowing what pathogenic role they play. There are a certain number of new viruses as well. The Professor Raoult's lab in Marseille, for example, found in outpatient mimivirus seroconversions. This is a giant virus that looks like a bacterium, and that's why they had some difficulty in identifying it. They identified a certain number of serotypes, and in our patients we were surprised to see that a certain number of them actually presented with a seroconversion to the mimivirus without being able to evidentiate them using PCR. So maybe they had been in contact with that in the days leading up to their hospitalization. And we also looked at mimivirus seroconversion in ventilated patients. You can see the results of this on the slide. So the mimivirus doesn't necessarily play a confirmed pathogenic role. All of this information is somewhat new, but there are things that are much more simple to digest. This is something that we did last year. It's not very flattering for us, but I will mention it to you because it contradicts everything that I've said. During 1 month, we found we have about 14 beds in our IC ward, and half of them we found an adenovirus in a period of 1 month, over a period of 1 month. A certain number of these patients were lung transplant patients. So I'm not going to talk about the impact for their life prognosis. I don't know whether it modified their life prognosis or not, but just to show you the precautions that we have to make. We did this study in autumn of 2013. We did the epidemiological tests on all of the medical team and the healthcare givers. And by going back in time, we saw that we had 2 carriers, one who was asymptomatic and the other who was symptomatic. And when we looked at the wardrooms that the patients had been hospitalized in, these people had actually been looking after patients who had been positive to this PCR. So you see there is a risk of transmission. Again, the pathogenic role in this story is perhaps very slight, but nonetheless, we're always saying that you should wash your hands. We can never say it enough. But there are a certain number of other precautions that one should take if you've got a runny nose or if you're sneezing all the time. This is something that I think we should better highlight amongst our younger staff and even amongst some of the more senior staff, which leads me to my very last slide concerning possible prevention by vaccination. We could talk about flu here rather than just talking about HSV and CMV, and this is a test that comes from the Netherlands. It was a randomized test that was done in 6 of the university hospital centers in Holland. The 2 others already have a very considerable flu vaccination program. A certain number of things were done in these 6 hospitals to facilitate the vaccination process, and they showed that you can literally double the number of subjects that are opting for vaccination. And they had taken pediatrics and internal medicine in their trial, and they saw that in the teaching hospitals where the flu vaccine had been promoted, they had a lower rate of pneumonia, either non-documented or viral pneumonia. So the flu vaccination was beneficial. So by way of conclusion, I'd just like to stress the point that reactivation of HSV and CMV is relatively frequent. Its pathogenicity remains to be further explored, even if I am firmly convinced that it will modify the patient's prognosis, be it directly or indirectly. There are a certain number of other trials that are ongoing other than ours, but they tend to be focusing on other endpoints or on other very specific population groups. And as we saw earlier when we were talking about community-acquired infections, and it'll probably be the same for nosocomial infections amongst hospitalized patients, is that thanks to the progress in our diagnosis techniques, we will probably be increasing the number of viruses that we identify. But let's keep our feet firmly rooted on the ground. Let's look at the antiviral agents while simply at the same